Hi, my name's Dr. Michael Garcia Roig. I'm a pediatric urologist at Georgia Urology, and today we're going to talk about some common pediatric scrotal problems. Just a little bit about me. Like I said, I'm a pediatric urologist here at Georgia Urology. I did my urology residency at the University of Miami, then my pediatric urology fellowship for 2 years here at Emory in Atlanta, and I've been at Georgia Urology since 2016. A little bit about us. Our pediatric practice was founded in 1975. We currently have 8 attending pediatric urologists and go to 10 office locations around Atlanta. We train future pediatric urologists and have 2 fellows with us. And we operate at 4 surgical locations at the moment. In 2023, we did about 6,000 cases, and we have a Da Vinci robot to do robotic surgery. So my talk is in 2 parts. We're going to cover part 1 today. We'll talk about just some basic anatomy of the scrotum, hydroceles and hernias, varicoceles, and undescended versus retractile testicles. So let's move on to the anatomy. So the testicle lives in the scrotum. That's the purpose of the scrotum, is to house the testicle. There are 2 testicles. The testicle itself has a few parts. The largest portion here on the right side is the testicle itself, and this more tan-colored structure is the epididymis. So sperm is produced inside the testicle. It travels through a really long tube inside, and then its last course out through the testicles through the epididymis, where it matures, and then they come out through the vas deferens. And the vas deferens connects to the prostate. So this slide is to go over this structure called the processus vaginalis. It's going to come up a few times in our talk. So this structure is an outpouching that forms while a baby's still inside their mother. Testicles, when they initially form, they form inside the belly, in the abdomen, and during development, they descend down into the scrotum. Now, before the testicle comes down into the scrotum, the processus vaginalis creates the space from the belly down into the scrotum for the testicle to come down. Now, the neck of the processus vaginalis is supposed to close up around the time of delivery or soon after. And sometimes that doesn't quite happen completely, which we'll touch on in a little bit. So what is a scrotum? We just talked about it holding the testicles, but it actually serves a purpose besides only holding the testicles. It's intended to regulate the temperature that the testicles live in, because the testicles have to be just a few degrees cooler than the core body temperature, about 2 or 3 degrees cooler. And that needs to happen so that the testicles can develop correctly and in adulthood so that they can produce sperm. They do this simply by, when it gets cold, the scrotum shrivels up and pulls the testicles closer to the body. And when it's warmer, the scrotum relaxes and lets the testicles hang a little further outside the body so they can cool down. And the scrotum actually also protects the testicles, obviously. So let's start with our first topic of hydroceles. So the definition of a hydrocele is fluid that collects in the space where the testicle lives within the scrotum. The testicle lives in a sac called the tunica vaginalis, and normally there's nothing in there, no fluid, no other material. But it's a potential space, and fluid can build up for different reasons. Now, we define hydroceles. We break hydroceles up into communicating hydroceles and non-communicating hydroceles, and we're going to talk about what that means in just a little bit. This fluid accumulation, when it happens, it's not painful, and the fluid being there doesn't harm the testicle or affect the testicle's function in any way. Sometimes when you have a fluid accumulation like that, it can give a bluish tint also. which is not necessarily concerning, but can be concerning to families. So first, what's a communicating hydrocele? A communicating hydrocele means that there's a connection between the scrotum and the belly. And you can see in this image here that fluid is able to make its way from the belly down into the scrotum, and it gets pulled down by gravity. What this represents is that processus vaginalis still being there. It's a patent processus vaginalis. Parents will sometimes come in saying that there's, the scrotum looks bigger on one side at the end of the day, smaller in the morning. And that's just the fluid coming in and out of the scrotum while the child is active during the day and upright. So gravity's pulling that fluid down, and the fluid goes away overnight because the child is horizontal, sleeping, and the fluid goes back into the belly. At the end of the day, this represents a very small inguinal hernia, an opening that's from one space to another that's not supposed to be there. And that small size allows only fluid to come in and out. These communicating hydroceles, in one form or another, are more common in younger kids. And the concern with this, if you do nothing, is that over time, as the child grows, that opening that's allowing fluid to come down is going to get bigger with the child as they grow, and other material besides fluid is going to make its way down into the scrotum, like intestines or abdominal fat, which we really don't want to happen. So what's a non-communicating hydrocele? A non-communicating hydrocele is a collection of fluid around the testicle with no communication between where the testicle lives in the tunica vaginalis and the abdomen. There's no patent processus vaginalis. This usually happens, this is something you usually see after some kind of inflammatory incident. Maybe there was an accident, an infection, maybe the child had surgery. Sometimes there's nothing the family can remember. But there was probably some inciting event at some point. True non-communicating hydroceles are much more often seen in teenagers and adults. The kids will, and the parents will say that really there's no change in size, or maybe just a slight gradual worsening only. In preteen kids, it's very common for non-communicating hydroceles to have a very small opening between the tunica vaginalis, where the testicle lives, and the belly. So really, in preteen kids, almost all hydroceles are considered communicating hydroceles until proven otherwise. Sometimes the communication can be really just a tiny little pathway from the belly down into the scrotum. But unless that's addressed at the time of surgery, the hydrocele will come back after correcting the hydrocele. So in newborns, we handle hydroceles a little bit differently. Hydroceles in newborns are very common. And often, when they're present from when the child's born, they tend to go away within the first 12 to 18 months, whether they're communicating or non-communicating. So if the child's doing well, if there's only fluid felt within the scrotum, really the best thing for those kids is just to monitor them with regular exams by their pediatrician or urologist to make sure it's kind of gradually getting better, and only fluid, again, is present within the scrotum and not abdominal contents like intestines or abdominal fat. If you have a child with a non-communicating hydrocele, and let's say 6 months later it turns into a communicating hydrocele, the parents start to say that fluid's coming in and out of the scrotum, that suggests that maybe it's not getting better. Maybe that opening is getting a little larger, and we need to correct correct this with surgery, or obviously if we feel intestines or abdominal fat on the exam, that's not a good thing, and that needs to be corrected. Now, if hydrocele, whether communicating or non-communicating, are present after the newborn period, those really tend not to go away. That new fluid suggests a patent processus vaginalis until proven otherwise, and those need surgical correction. So just to review management, in newborns, we talked about observation being the mainstay in the majority of kids, and these tend to resolve really in the vast majority without surgery. But if they get very large over time or progressively larger, if we think they're uncomfortable, if the physical exam changes or they persist, then we can go ahead and correct these. When they present after the newborn period, they also need surgical correction. And in teens, if it's a very small hydrocele, fluid that really only a specialist is feeling or is only seen on an imaging study, but the child doesn't perceive it. Remember that the fluid itself doesn't cause a problem. And observation is probably recommended for those really small hydroceles. But if they're bigger, sometimes they can get really quite large and kind of get in the way and become quite bothersome. Those do need surgery to correct them. So the goals of surgery to correct a hydrocele are to make sure processus vaginalis is present or not, and tie it off if it's present. We'll obviously remove the fluid from around the testicle, and we want to prevent hydroceles from coming back, and you do that by opening the fluid sac so that the testicle can scar in place, which prevents fluid from reaccumulating. These can be addressed. There are dozens of different techniques to address pediatric hydroceles and hernias. Basically, they can be divided into open or laparoscopic procedures. This is really the surgeon's preference. There's no benefit that's been shown between one approach or another, and the outcomes are thought to be identical. The surgery tends to take about 30 minutes for one side. Kids very much go home the same day, and the feedback I get from parents is that kids recover quickly, sometimes a little quicker than I would like them to. Like they're back to, especially younger kids, like the 2-year-olds are back to running around and being very, very busy, sometimes the day of surgery or the next day. The overall rate of complications with this procedure is also very low, about 1% or less. So these kids tend to do well. Okay, so on to varicoceles, our next topic. So what's a varicocele? Varicoceles are, to put it simply, they're varicose veins of the testicle. The same varicose veins that happen in the leg that we're familiar with are happening in the scrotum. The veins that are dilated are the veins that drain the blood from the testicle. The classic description in our textbooks is that it looks like a bag of worms, because it kind of does, and it feels that way on physical exam. These are not that uncommon. They happen in 10 to 25% of late teens, depending on which study you look at, and they're present in about a third of adults. The majority of these cause no symptoms and cause no problems, and they are very rarely painful. The statistic is about 3% of these are uncomfortable. Varicoceles tend to be more common on the left side, and that's because of the way we are kind of built internally, our internal anatomy. On the left side, the vein that drains the blood from the testicle on that side drains all the way up into the kidney. It's a vertical trajectory from the testicle to where it drains into the kidney, and it's thought that creates a higher pressure column of water. So these small veins have little valves inside, normally, that prevent backflow within the vein. And some people believe that varicoceles are caused by those valves not working correctly, meaning they don't prevent backflow efficiently, and blood can flow in the wrong direction in the vein. On the right side, for those of you who are interested, the vein that drains the blood from the testicles is not quite as long, and it also has more of an angled trajectory. It drains into the inferior vena cava and is thought to have a lower pressure column of water, which is why they're less common on that side. So why do varicoceles matter? Really, fertility. This pooled blood in the scrotum changes the temperature that the testicles live at. It makes them warmer. And like we were talking about before, the testicles need to live at a different temperature so that they can develop correctly and function correctly in adulthood. That warmer temperature impairs testicular growth and sperm production in some people. So, if someone has a varicocele and that someone also has abnormal sperm production, we know that those people go on to have fertility problems. They have a hard time having kids. Not everyone with a varicocele is going to have these fertility problems. It's about 10 to 15% of people with a varicocele have an abnormal sperm count and abnormal sperm production. So our job with varicoceles is really teasing out who has these abnormalities in sperm production and who needs treatment. So how do we, evaluate and follow kids with the varicocele? We start with an ultrasound, obviously a physical exam, and sometimes we also do a semen analysis. So what are we looking for? When we're doing an ultrasound, obviously we're looking to make sure that the testicle itself is okay, is normal on the inside. But we know that in people with a varicocele, their total testicular volume, people have correlated that with sperm count, and also a difference in testicular size of about 15% has also been correlated with sperm count. So if the left testicle is more than 15% smaller, the left side with the varicocele, that has a pretty fair likelihood of being associated with an abnormal sperm count. Now, the catch here is that we're really kind of indirectly looking at sperm count. And these measurements have been studied because it can be a little awkward for a teenager to give a sperm sample and do a sperm count. Lots of studies have looked at these testicular measurements, and we know pretty consistently that they have about a 25% false positive and false negative rate. In families that are amenable, I recommend doing a semen analysis or a sperm count. We're looking for a total motile sperm. Our practice has paired with a company called Fellow that has at-home mail-in kits, which I think helps with a lot of that awkwardness. And I think since we've had those kits has helped a lot of families move ahead with doing those sperm counts at home and then mailing them into the lab. So who needs treatment with varicocele? In families that decide to go the testis measurement direction, we're looking for a persistent testicular size discrepancy of more than 15% over a 1-year period. I say over a 1-year period because kids grow and their testicles also grow. Sometimes you have testicles that don't necessarily grow at the same rate, which is just natural for some people. And you may see a difference in size that kind of goes away over a 1-year period. Also, persistent total testicular volume less than 30 mLs has been associated with an abnormal sperm count. Now, if we're looking at sperm count directly, we're looking for an abnormal sperm count on 2 semen analysis. I say 2 semen analysis. That's the standard in fertility testing because sperm production is kind of a delicate process, and there are events or habits that can get in the way of testicular sperm production. So if we have one abnormal test, we'll repeat that test a couple months later to see if things normalize. Also, in kids who have testicular discomfort, those obviously need to be repaired. And some kids have a very, very large varicocele. As big as a hydrocele, and those need to be corrected also. In pediatrics, we typically repair varicoceles with laparoscopic ligation of the testicular vessels. This works well at correcting varicoceles. About 90 to 95% of the time, it corrects the varicocele. Afterwards, we follow kids with either ultrasound to look for any catch-up growth in the testicle that we've corrected surgically, or we repeat a semen analysis a few months down the road to see if the testicles have started to produce sperm more normally. We expect to see catch-up growth, and we know that in kids when this is performed in the pediatric population, in kids with abnormal sperm parameters, you expect to see improvement in their sperm parameters, and the fertility rate in those people returns to being similar to the general population of about 90%. I just alluded to this, but with varicoceles, there's thought to be this window of opportunity in addressing the problem, in that, we know pretty reliably that if a child has a varicocele and abnormal semen parameters, if you repair the varicocele when that child is still a teenager or in their early 20s, you're going to have pretty reliable improvement in sperm parameters and a significant improvement in their fertility. But if you do nothing and someone waits until they're in their 30s, they can't have kids, and have the varicocele repaired at that time, it's much less reliable at improving fertility and the ability to have kids. And along that line, if all testing is normal in a teen, we do a sperm count, maybe do an ultrasound, the testicular measurements are well within normal, the sperm count, it looks perfect. But they clearly have a varicocele on physical exam. I recommend those kids consider repeating a semen analysis in their early 20s, just to make sure that nothing has changed in those couple of years while they're still within that window of opportunity. Okay, on to undescended testicles. So we talked about initially how the testicles develop inside the abdomen, in the belly. And during the development of the fetus, while the baby's still inside the mom, the testicle gradually comes down into the scrotum. And this happens at about 28 weeks of gestation. The process of testicular descent is pretty complicated. There are mechanics, muscles involved. There are hormones that turn on some of those muscles. There's neurotransmitters that are involved. And in each child, we honestly will not know the exact cause of their undescended testicle. And it really doesn't change the management at the end of the day. Now, undescended testicles are pretty common in newborns. They happen in about 2 to 5%. So on the higher end, that's 1 in 20. And they're much more common in preterm babies. But a significant percentage of these come down on their own by about 4 months old, about 70%. If the testicle hasn't come down by then, there's a very low chance that it's going to come down on its own after that time. So why does an undescended testicle matter? We've hit on this topic a couple times. The testicles need to be in the scrotum so that they can develop correctly and be at the right temperature so the cells that produce sperm will continue to live and can produce sperm correctly when the time comes. There's also a pretty fair risk of testicular cancer in testicles that remain outside the scrotum. And there's also a higher rate of testicular torsion in untreated undescended testicles. So, what's the timing of addressing this in babies? We know that if they don't come down by 4 months, the chance they're going to come down is pretty slim. And those cells that are responsible for producing sperm, Sertoli cells. They're always there. They don't start producing sperm until the child goes through puberty, but they're pretty sensitive to those changes in temperature at any age. And in studies where biopsies of testicles have been done at the time of this surgery, we know that those Sertoli cells start to kind of slowly decline in number after about 6 months old. Positioning the testicle back into the scrotum in the appropriate time frame helps keep those cells alive so that that testicle can produce sperm when the time comes. Like I mentioned also, there's a significantly higher risk of testicular cancer than the general population. Bringing the testicle down into the scrotum before puberty drastically reduces that risk. It doesn't bring it back down to the same as the general population, but it's way lower than 8-fold higher. Now, in order to have that benefit of reduced cancer risk, the surgery has to be done before the child is a teenager. If the testicle has been undescended since birth, and for some reason it's not addressed until the child has already started puberty, then our guidelines actually recommend removing that testicle because the risk of testicular cancer really is not reduced that much by doing the surgery. Okay, so how do we diagnose undescended testicles? This is really a physical exam finding. Imaging studies are very unreliable in determining the location of the testicles and are really not recommended per our society's guidelines. On a physical exam, undescended testicles are broken up into two basic categories, being palpable, meaning it can be felt on the exam, or non-palpable, that it can't be felt on the exam. Feeling it would be along the trajectory that the testicle descends, so anywhere from the groin down into the scrotum. And non-palpable testicles would be inside the belly where they initially develop. A lot of kids with undescended testicles have a patent processus vaginalis. Remember that structure that we talked about at the very beginning that helps the testicle come down into the scrotum and can be responsible for hydroceles. It tends to be present in these kids. And when we do surgery to reposition that testicle in the scrotum, part of the surgery is correcting that processus vaginalis. In kids who have a single undescended testicle, those kids are thought to have the same fertility as the general population. And now in kids who have two undescended testicles, they can have some fertility concerns. It's thought that their infertility rate is about 35 to 50% after appropriately timed surgery. If the surgery is delayed significantly or not done, then I think infertility is really more the rule. As far as fertility, I want to put a little asterisk here. This is something to, I think, be cautious about when you Google this topic, because I actually had to do some digging and some research in preparing this talk. There's some literature out there that's based on biopsies that shows changes in cells that suggest that the infertility rate may be higher with kids with a single undescended testicle. But in studies that actually look at those people's ability to have kids, the difference is thought to be similar to the general population with just a single undescended testicle and a normal testicle on the other side. So retractile testicles are often confused with undescended testicles. In boys before puberty, they all have a reflex that pulls the testicle up from the scrotum up towards the belly. This is present in all kids, and the degree to which that reflex is present varies. Some kids have a really prominent reflex. Maybe it pulls the testicle up higher. The reflex has a lower threshold to elicit that muscle contraction, or the muscle itself is stronger. And it can make the physical exam very challenging if the testicle is pulled up all the way into the inguinal canal or into the groin area where the skin and fat are much thicker. It's thought that kids with very retractile testicles have the possibility of developing an ascended testicle, which we'll talk about in a minute. But at the end of the day, ascended testicles are pretty uncommon in the general population. And this is what your pediatrician is checking for every year to make sure that the testicles remain in the scrotum. That's what they're checking for when they do a genital exam. So what's an ascended testicle? A child with a previously descended testicle, the testicle can ascend, meaning it's no longer located within the scrotum, or it can't be brought down to the scrotum, or if it can be brought down to the scrotum, it immediately floats back up because something is holding it up. The exact reason why this happens is not very clear. I'll tell you what I find when I correct these. The fascia that runs along the cord sometimes is much tighter. Some of these kids, the structure that holds the testicle in the scrotum, which is called the gubernaculum, maybe is kind of loosey-goosey and doesn't hold it down very well. Or some of these kids have patent processus vaginalis or a hernia. Just like undescended testicles, this needs to be addressed. The testicles need to be repositioned back into the scrotum with a procedure. In an ideal world, just like a newborn, it should happen within 6 months of this being noticed. And those kids have the same benefit from the procedure in that the testicle will function normally once it's repositioned to the scrotum, and that risk of cancer is decreased. So what does surgery look like for an undescended testicle? If the testicle is palpable, meaning the doctor can feel it in the groin, we make a little cut in the groin and another one in the scrotum. We want to make sure there's not a hernia present, and if it is, we'll correct it at the time. And then that testicle is repositioned into the scrotum. This surgery works well. It tends to be successful in about 95% of kids when the testicle can be felt on a physical exam, and success means the testicle makes it all the way down to the scrotum. Kids go home the same day, and the reason we do this, just to review, is to preserve sperm production, to reduce the risk of testicular cancer in the long run, and so that testicle is in an area where the child can do testicular self-exams when they're older. If we can't feel the testicle on a physical exam, things are a little more complicated. Our goal is to find that testicle or whatever its remnant was, and if possible, bring it down to the scrotum. So first step here is once the child is asleep under anesthesia, we really want to re-examine that child a little more closely. Sometimes in the office, the exam can be challenging if the child is just not cooperative, or if the reflex that pulls the testicle up that we were talking about maybe has pulled the testicle out of the way. If we still can't feel the testicle with an exam under anesthesia, then we need to look inside the belly by doing a diagnostic laparoscopy and see if that testicle is in the abdomen. And there are a handful of possibilities like you see listed here. We might find a nice testicle with a long vas deferens and gonadal vessels and be able to reposition that testicle in the scrotum right away. It's also possible to find the testicle with a long vas deferens. That vas deferens is the tube that carries the sperm out of the testicle, and short gonadal vessels, short artery and vein that go to the testicle. We might also find a testicle with both short vas deferens and gonadal vessels, or remnants of what was a testicle, a very small nubbin of scar tissue, sometimes no signs at all of a testicle, which is called a vanished testicle. And what we do from that point also depends on what we find. So if that testicle has a nice, long, healthy vas deferens and blood vessels, we'll try to bring it down right in one step. If it has a long vas deferens and short vessels, depending on the findings, we may bring the testicle down in one surgery or two surgeries, depending on the features of the vas deferens and some of the other anatomy. Now, if the testicle has short vas deferens and blood vessels, or if there's a very atrophic or abnormal remnant of a testicle, or if the testicle has vanished, that material is removed and we're done. There's no more surgery for those kids. So after surgery, what can you expect? There are some kids where after bringing the testicle down to the scrotum, the testicle really may not survive the procedure, that particular testicle, and it may atrophy or shrivel up. That happens in about 2% of kids where the testicle is brought down through the groin and the scrotum, like I talked about initially, and about 10 to 20% of the time when the testicle is initially present inside the belly. Now, if the testicle atrophies and there's a normal testicle in the scrotum on the other side, those kids actually do well. They will grow normally. They are expected to have normal hormone levels and also the same fertility as the general population, because that remaining testicle will grow larger to make up for what the other one's not doing and compensate. Also, after surgery, regardless of where the testicle starts off, it's a good idea to have the child come back around the time that puberty starts to talk about testicular self-exams, because this surgery does reduce the risk of testicular cancer, but it doesn't bring it back down to the same as the general population. And it's a good practice to have that conversation with everyone in the room, that they need to be aware of what that testicle feels like and say something if they feel a new lump, so that we can get an ultrasound. We touched on teenagers. If the testicle has been undescended since birth, those are the recommendation is to remove those testicles, because there's a significantly elevated risk of cancer in the long run. And we know that that testicle is not going to produce sperm at any point. If we're pretty confident that the testicle was down at some point before, then we can assume that isn't an ascended testicle, and those are repositioned back into the scrotum with an orchidopexy.